we will discuss joints of the upper limb. We will focus on the joints of the shoulder girdle and the shoulder joint. Let's start with the shoulder girdle, and when we mention shoulder girdle, we mean two joints. One of them is sternoclavicular joint, and the other one is acromioclavicular joint. Let's start with the sternoclavicular joint. Its type is synovial saddle. The articulating bones are the medial end of the clavicle and the clavicular notch of the sternum and the first costal cartilage. It is atypical because the articular surfaces are covered by fibrocartilage and not hyaline cartilage, and it contains articular disc, and this articular disc is fibrocartilaginous. It is attached to the inner surface of the capsule, and it is firmly attached from above to the medial end of the clavicle and from below to the first costal cartilage. The important ligaments are anterior and posterior sternoclavicular ligaments, interclavicular ligament, which connects the two heads of the two sternal ends of the clavicle from above, the costoclavicular ligament, which is attached to the rough area on the inferior surface of the clavicle and the upper surface of the first costal cartilage. Actually, the stability of this joint, there are no many muscles around this joint, so its stability relies on the ligaments. The movement, elevation and depression of the acromial end of the clavicle result in depression and elevation or downward and upward movement of the sternal end of the clavicle and the disc between the sternal end of the clavicle and the disc. However, the forward and backward movement of the acromial end lead to a forward and backward movement at the sternal end. This movement occurs between the manubrium sterni and the disc. So the elevation and the depression movement occur between the clavicle and the disc. However, the anterior and posterior movement occur between the manubrium sterni and the disc. And also the rotatory movement, as in abduction of the shoulder, occurs between the manubrium sterni and the disc. The stability of this joint is maintained by the ligaments, and the strongest one is the costoclavicular ligament. It will take all the strain, transmitting the stress from the clavicle to the first costal cartilage. Then this first costal cartilage is fixed to the manubrium sterni by the primary cartilaginous joint between both of them. This location is unusual in this region, and usually the clavicle will be fractured. Sternoclavicular joints injury, there will be dislocation, either anterior or posterior dislocation. Anterior dislocation, the medial end of the clavicle project under the skin, and it will be pulled upward by the action of sternomastoid muscle. The posterior dislocation occurs from as a result of direct trauma applied to the front of the joint. The clavicle will be driven backward, and it might injure important structures like the trachea, like the esophagus, like the major blood vessels in the neck. The second joint of the shoulder girdle is the acromioclavicular joint, and its type is plain synovial. It is articulation between the lateral end of the clavicle, we call it acromial end, and the articular facet on the medial border of the acromion process. The articulating surfaces are also covered by fibrocartilage, and it contains disc. Important ligaments here, one superior and one inferior acromioclavicular ligament, and the strongest one is the coracoclavicular ligament, which has two parts, conoid part and trapezoid part. The conoid part is attached to conoid tubercle on the undersurface of the clavicle and base of coracoid process. However, trapezoid part is attached to trapezoid ridge on the undersurface of the clavicle and superior surface of coracoid process. This ligament is important for transmission of the weight of the upper limb to the axial skeleton. Fracture of the clavicle medial to this ligament will lead to drop of the upper limb. Stability factors in this joint relies on the ligaments, and mainly this coracoclavicular ligament. This is the movement summary of the movement occur at the shoulder girdle. Elevation of the shoulder occur by levator scapulae and upper fibers of trapezius. However, depression occurs by pectoralis minor and lower fibers of trapezius and the gravity. Protraction occurs by serratus anterior. However, retraction occurs by the middle fiber of trapezius and rhomboids. Upward rotation of the scapula occurs by trapezius and serratus anterior. Downward rotation of the scapula occurs by rhomboids and pectoralis minor muscle. Movement of the shoulder girdle. When there is abduction of the arm, the total range of scapular rotation is 60 degrees. 20 degrees of them occur between the scapula and the clavicle. The two parts of the coraco when rotation starts to occur between the scapula and the clavicle, the coracoclavicular ligament become taut and transmit the rotating force to the clavicle, and this clavicle which rotate and its rotation is responsible for the remaining scapular rotation on the chest wall. The scapula and the upper limb are hanged by the conoid part of the ligament, coracoclavicular ligament, and assisted by deltoid biceps and the triceps muscle. However, the force transmitted medially from the upper limb to the glenoid cavity are transmitted from the scapula to the clavicle through the trapezoid part of the coracoclavicular ligament, and from the clavicle to the first rib by the costoclavicular ligament. For an outstretched hand will put no strain on the either ends of the clavicle. Regarding the shoulder joint is a bolus and socket joint. The articulation, the head of the humerus, about third of the head of the humerus will fit into the glenoid cavity. The capsule is attached to the margins of the glenoid fossa. It is attached to the anatomical neck, and in its lower part, it will descend to be attached 1.5 centimeters below the anatomical neck. There is one hole admitting for the passage of the tendon of long head of biceps, and another hole anteriorly communicate with the subscapular bursa, and another hole posteriorly communicate with infraspinatus bursa. The weakest point is inferior because it is not supported by the rotator cuff muscles. The rotator cuff muscles are the supraspinatus support the joint from above, the infraspinatus anterior minor support the joint from behind, and subscapularis support the joint from the front. Synovial membrane is lining the capsule, and it is attached to the margins of the labrum, glenoid labrum, and it is attached to the articular margins of the disc, and it will cover the part of the humerus, which part of the neck of the humerus which lie inside the capsule of the joint. It will herniate to cover the long head of biceps. Regarding the ligaments, there are coracohumeral ligament, and this coracohumeral ligament is attached between the coracoid process and the greater tuberosity. It is a strong ligament. It starts from the base of the coracoid process to the front of the greater tubercle of the humerus. It will blend with the capsule. There are glenohumeral ligaments, and they are three: superior and middle and inferior. They are better to be seen from the inner surface of the joint capsule. They are attached between the glenoid labrum and also the humerus, the greater tubercle of the humerus. There is ligament between the glenoid cavity and lesser tuberosity. Transverse humeral ligament, which is attached between the lesser tuberosity and the greater tuberosity. It will cover the passage of, it will cover the long head of biceps, so it will lie in a tunnel. The labrum glenoidale or glenoid labrum, it is a fibrocartilaginous ring. It helps to increase the depth of the glenoid fossa. Regarding the coracohumeral ligament is attached from the medial border of the acromion to the lateral border of the coracoid process. It lies above the head of humerus. It will support the head of humerus. It is separated from the rotator cuff muscle by subacromial bursa, and the lower layer of the subacromial bursa is attached to the tendon below, and the tendon below is the tendon of supraspinatus. It extends here beyond the level of beyond the lateral border of the acromion. When the arm beside at the side, but it will roll inward under the acromion when the arm is abducted. The coracohumeral ligament, this one, tenderness over the greater tuberosity, especially of the humerus, under cover of deltoid muscle, which disappear when the arm is abducted. The painful arc actually between 60 and 120 degrees. It is called the painful arc, where there is impingement of the subacromial bursa below the coracohumeral ligament. It might lead to tearing of the supraspinatus ligament, and the supraspinatus ligament, because of this ligament will have necrosis here, a vascular necrosis here. When it ruptures, the subacromial bursa might communicate with the capsule of the shoulder joint, which is normally didn't happen. Anastomosis around the shoulder joint. There are multiple arteries forming anastomosis around the shoulder joint, either branches from the subclavian artery, like the suprascapular artery and the transverse cervical artery, branches from the axillary artery, like anterior circumflex humeral, posterior circumflex humeral, and the subscapular artery with each branch is circumflex scapular artery. Stability of this joint, actually, this joint most frequently to be dislocated in the body. It is strengthened, the capsule is strengthened by fusion of its tendon with the rotator cuff muscles, with reinforced by ligaments like glenohumeral ligament, coracohumeral ligament, and supported from above by the coracoacromial arch. It becomes deepened by the labrum glenoidal. Also, there is a splinting effect of the long head of biceps and the triceps. The upward displacement of the head is prevented by the coracoacromial arch and the subacromial bursa. Dislocation of the shoulder joint may damage the axillary nerve when as it runs around the surgical nerve. Regarding the movement, flexion and the range of flexion is 90 degrees. It occurs by many muscles like deltoid, biceps, pectoralis major, and coracobrachialis. Extension 45 degrees, its range. It occurs by many muscles also like triceps, like posterior fiber of the deltoid, latissimus dorsi, like teres major muscle. Adduction, its range 45 degrees. It occurs by the three muscles attached to the bicipital groove, the pectoralis major, the teres major, the latissimus dorsi, and also the subscapularis. Abduction, it has degrees from 0 to 15 by supraspinatus, 15 to 90 by deltoid muscle. Medial rotation 55 degrees occurs by the muscles attached to the bicipital groove, also the latissimus dorsi, the teres major, the pectoralis major, also deltoid and subscapularis. Lateral rotation from 40 to 45 degrees by infraspinatus, teres minor, and deltoid muscle. Abduction of the arm involve rotation of the scapula. For each 3-degree abduction of the arm, 2 degree of abduction occurs at the shoulder joint and 1 degree of abduction occur at the shoulder girdle. At about 120 degree abduction of the arm, the greater tuberosity of the humerus come in contact with the lateral edge of the acromion. Further elevation need rotation of the scapula. At 90-degree abduction, the upper part of the articular surface of the humerus is fully utilized and lie edge to the glenoid fossa, so we need to lateral rotate the humerus to bring more articular surface in contact with the glenoid cavity to help to continue the abduction. So this is overview on the shoulder girdle and shoulder joint, and thank you.